Hello doctors, I hope everyone is doing great. Welcome to Easy Medicine. As we all know how important it is to do past papers of UHS for class tests, stand-ups and final exams. Today we will discuss past papers of UHS for final year MBBS. In this video we will discuss Medicine Paper 1. Before starting, it is better to have an overall view. So here I have provided you with distribution of marks for Medicine Paper 1. Today we will discuss respiratory diseases, and as you can see you will have one question from this topic in your Medicine Paper 1. Also, I would like to tell you that with every answer you will see a blue box in right corner of your screen. It will provide you with the page number of Davidson's Book of Medicine from where the answer is taken, so that you can authenticate the answers yourself. I have done this to make sure that you can put your mind at ease about how accurate these answers are, as all of them are taken from a good UHS recommended book. For the purposes of this video, page numbers are taken from 22nd edition of Davidson's Book of Medicine. Let's begin. The first question is, a 35-year-old thin male non-smoker presents with a history of sudden onset of right-sided pleuritic chest pain and shortness of breath. On examination, blood pressure is 120/80, pulse is 90 per minute and no cyanosis. Respiratory examination reveals hyperresonant percussion note and reduced breath sounds on right side of the chest. Trachea is central. This question was in annual examination of 2018. The first part is, what is the most likely diagnosis and etiology? Second part is, what are other types of this illness? And the last one is, discuss the guidelines of managing such illness. You can stop the video here and try to answer the question on your own before we move forward. Very good. So the answer is primary spontaneous pneumothorax. I have seen students struggle more with reaching a diagnosis than with answering the subsequent questions. I will try to solve this problem by explaining that how we reach to a specific diagnosis. So in this question, the points which led us to this diagnosis are acute onset of shortness of breath, unilateral hyperresonant percussion note, and unilateral decreased breath sounds. Let's see the answers now. Here, see the diagnosis is right-sided primary spontaneous pneumothorax, and its etiology will be primary spontaneous. The next question asks about what are its different types. So there are two ways to classify this disease. The first way is based upon its etiology, and depending upon its etiology there are two types, spontaneous and traumatic. Spontaneous is further divided into primary or secondary, and the second way to classify is based upon the type of the lesion, and it can be open, closed, and tension type. The third question asks about the management of this illness. Remember that whenever management of an illness is asked, start with history, physical examination, then investigation, and finally the treatment as it is shown here. Do not write treatment only in questions which ask about management. Management of primary spontaneous pneumothorax is done under following guidelines. First, check for tension pneumothorax or chronic lung disease. If they are present, then immediately place intercostal drainage tube in fifth space. However, if they are absent, then check if there is severe dyspnea or more than 15% of hemithorax is involved on chest X-ray. If any of these is present, then initially perform percutaneous needle aspiration. However, if pneumothorax persists, then place intercostal drainage tube in fifth space, as we did in the first part. And as discussed, here is the reference page number from Davidson's Book of Medicine. Let's move to the next question. The first question is, a 35-year-old male presents with history of fever with rigors from last 3 days, along with pain in right lower chest which aggravates on coughing. Examination shows temperature of 104, pulse is 120 per minute, blood pressure is 85/40, and respiratory rate is 36 per minute. X-ray shows patch of opacity in right middle lobe with obliteration of costophrenic angle. This question was in supplementary examination of 2018. The first part is, what is the likely diagnosis, what complication has occurred, where this patient should be managed, give justification. The second part is, what are 4 principles of management. Enumerate any 6 extrapulmonary complications of this disease. The second question is, a young male patient is referred to you from a mental health facility with fever, cough, rusty sputum and pleuritic chest pain for last 2 days. X-ray shows parenchymal infiltrates. and this question was in supplementary examination of 2017. The first part is, what is the diagnosis? The second part is, what are possible complications? The third part is, what are usual organisms involved? Please try to answer the question on your own before we move forward. Great, so the answer is lobar pneumonia. And as I have discussed before that students mainly struggle with reaching a diagnosis and nobody explains that how you come to a diagnosis, the important points which led us to this diagnosis are high fever, productive cough, a chest pain that aggravates on coughing. This type of chest pain is called pleuritic chest pain. Also, there is an extra evidence of opacity in the lung lobe. Let's see the answers now. See, here the diagnosis is lobar pneumonia. The second part of the question asked about complication which has occurred. The complication is parapneumonic effusion. The next part asked where the patient should be managed. So this patient must be managed inside a hospital because of his CURB 65 score. So a CURB 65 score is to determine whether the patient should be managed inside a hospital or not. A score of 2 or more indicates in-hospital management, and our patient had CURB 65 score of 2. So the CURB 65 score stands for confusion, blood urea nitrogen more than 20 mg per deciliter, respiratory rate more than 30 per minute, blood pressure less than 90 systolic or less than 60 diastolic or both, and age more than 65. Each of these carries 1 point, and depending upon how many of these a patient have, his CURB 65 score is calculated by adding them together. Next part of the question asked about management, and as discussed, every management begins with history, examination, investigation, and finally treatment, which here involves oxygen administration, intravenous fluids, antibiotics and analgesics, nutritional support, and finally follow-up at 6 weeks. While treating the patient, most of the doctors forget about nutritional support, and it is very essential because a patient will not get better despite giving appropriate medication if his nutrition is not managed. Next part of the question asked about extrapulmonary complications. So here I have given pulmonary complication and extrapulmonary complication. Pulmonary complications are empyema, lung abscess, pneumothorax, and acute respiratory distress syndrome, which is abbreviated as ARDS. Extrapulmonary complications include hepatitis, pericarditis, myocarditis, renal failure, deep venous thrombosis, and ectopic abscess. The second question also asked about usual organisms, and usual organisms involve bacteria and as well as viruses. Bacterial organisms are Streptococcus pneumoniae, Legionella, Staphylococcus aureus, and Klebsiella. Viruses involved are influenza, parainfluenza, coronavirus, adenovirus. Here you can see right middle lobe of the lung is involved in lobar pneumonia. And here is the reference page number of Davidson's Book of Medicine. Let's read the next question. The first question is, a 60-year-old male with progressive shortness of breath and cough with sputum for last 6 months presented with increased symptoms, deterioration of health status and lung functions. He is a smoker, febrile, with blood pressure of 130/85, pulse 110 per minute, and respiratory rate as 30 per minute. This question was in annual examinations of 2017. The first part of this question is, what is your diagnosis? Next is, name 3 triggering factors for his condition. Next is, and list steps of management. The next question is, a 60-year-old heavy smoker for last 20 years presented to emergency room with severe dyspnea, central cyanosis, and fever. Patient has past history of tuberculosis with pleural effusion on right side, which was treated with anti-tuberculous therapy with no residual effect. His BP is 150/90. Respiratory rate is 30 per minute. Chest examination shows bilateral crepitations and wheeze. This question was in supplementary examinations of 2015. The first part of this question is, enumerate 4 investigations for this patient. Next is, what is the management of this patient? And the last is, what is the risk of giving high concentration of oxygen to this patient? Please try to diagnose on your own before we move forward. Well done. So the diagnosis is acute exacerbation of COPD, and important points which led us to this diagnosis are long history of smoking and sudden increase in baseline symptoms such as dyspnea. Let's see the answers now. So the diagnosis is acute exacerbation of COPD. The next part of the question asked triggering factors of this condition, which are bacteria, viruses, and change in quality of air. The next part of the question asked about the management, and the management involves history, examination, investigations, and finally the treatment. In history of this patient, severity of dyspnea and smoking frequency must be asked. In examination, general physical examination and focused chest examination must be done. Investigations involve complete blood count, chest x-ray and spirometry, which will show obstructive pattern, which is given by FEV1 over FVC ratio of less than 70%. And these three investigations are really important to diagnose COPD. Other investigations which can be done are measurement of lung volumes, high-resolution CT scan, alpha-1 antitrypsin assay. This last investigation is reserved for COPD in children. Next part is treatment. And treatment involves controlled oxygen administration nebulized with short-acting beta-2 agonist in combination with anticholinergic agents, oral prednisolone, antibiotics. If improvement with above therapy does not occur, then non-invasive ventilation is started with CPAP or BiPAP. The second question also asks the risk of giving high concentration of oxygen to the patient, which will be respiratory depression and worsening acidosis. And here you can find the page number from where this answer is taken. Let's do the next question. The first question is, a 25-year-old male presents with history of chronic cough which is productive with occasional episodes of hemoptysis for 2 years. His past history is significant for pulmonary tuberculosis when he was 10 years of age. Examination shows bibasilar coarse crackles. He is afebrile with ESR of 10 mm per hour. The first question is, what is your diagnosis? The next is, write 2 investigations to support your diagnosis, and finally outline the treatment options. The next question is, a 35-year-old male has been diagnosed with pulmonary tuberculosis 2 years ago. He has taken anti-tuberculous treatment for 9 months. For the last 6 months, he has increased cough, copious sputum, usually in the morning, brought on by posture change. Examination shows tachypnea, temperature of 101, pulse is 110 per minute, and digital clubbing is present with bilateral coarse crepitations. The first part of this question is, what is your diagnosis? Second is, how will you confirm your diagnosis? And the last is, enlist steps in management. You can stop the video here and try to answer these questions on your own before we move forward. So the answer is bronchiectasis due to pulmonary tuberculosis. The points which led us to this diagnosis are chronic productive cough and past history of pulmonary tuberculosis. Increased sputum production with posture change, especially in the morning, is also very characteristic of bronchiectasis. Let's see the answers. Here, see the diagnosis is bronchiectasis due to pulmonary tuberculosis. The next part of the question asked, how will you confirm your diagnosis? So, to confirm the diagnosis, you will do following investigations, which are sputum culture, CT scan, chest x-ray, electron microscopic examination of cilia. One important point about investigations is that CT scan is very sensitive for bronchiectasis. However, chest x-ray is not that sensitive, and examination of cilia is done only for bronchiectasis in children. As you can see in the picture, CT scan will show dilated air spaces, which are due to destruction of the walls of the airway due to bronchiectasis. The third part of the question asked about management, which will begin with history, examination and investigations, and finally treatment. And the treatment is physiotherapy, which involves postural drainage, also antibiotic therapy, surgical excision, which is only recommended if bronchiectasis area is confined. Also, if there is airflow obstruction, inhaled bronchodilators and corticosteroids are used. You can see in the picture how postural drainage is done, in which the patient lies on his side, and here is the blue box in which you will see the reference page number for Davidson's Book of Medicine. Let's do the next question. First question is, a 27-year-old female with a 10-year history of persistent wheezing, cough, and shortness of breath was diagnosed with chronic persistent asthma. She was admitted in emergency room with acute exacerbation after upper respiratory infection. Investigation shows complete blood count of 15,000, platelets 195 into 10⁻³ hemoglobin 14.5 gram per deciliter. This question was in supplementary examination of 2016. The first part of this question is, write any 4 triggering factors for asthma exacerbation apart from infections. The second part is, how she should have been managed in last 10 years. Write down various drugs with one preferred drug in each step. Last question is, outline management in acute exacerbation. Next question is, a 26-year-old male presents with complaint of shortness of breath and dry cough for 2 weeks, which is gradually worsening. He has similar episodes every year in spring. His father has history of atopic dermatitis. There are bilateral wheezes in chest. First part of this question is, what is your diagnosis? Second part is, how will you diagnose this condition? Third part is, give 4 treatment options to treat this patient, and this question was in supplementary examination of 2014. You can stop the video here and try to answer the question on your own before we move forward. The diagnosis is given away by first question, which is asthma. However, few important points which can lead you to the diagnosis of asthma are shortness of breath, dry cough, wheezing, and episodic nature of these symptoms. Let's see the answers now. As discussed, the diagnosis is asthma, and the triggering factors for asthma exacerbations are moles, pollens, air pollution, house dust mite, and cockroaches. The second question asked how to diagnose this condition. So asthma is diagnosed with following investigations, which are spirometry, measurement of peak expiratory flow, which is abbreviated as PEF, by peak flow meter. These 2 investigations are really important to diagnose asthma. Other investigations are skin prick tests and allergen-specific IgE detection in blood. One important point to remember about asthma investigations are that chest X-ray is usually normal in asthma. The next question asked how the patient should have been managed in last 10 years. Remember that chronic asthma is managed by a stepwise approach depending upon the severity of symptoms, and following are the treatment steps in order of increasing severity. In first step, short-acting beta-2 agonists are given, which are salbutamol, terbutaline. In second step, inhaled steroids are given, which are beclomethasone, budesonide, fluticasone. In third step, long-acting beta-2 agonists are given, which are salmeterol and formoterol. If the patient's symptoms are still not controlled, then in fourth step, you increase the dose of inhaled corticosteroids or add a fourth drug such as leukotriene receptor antagonist or theophylline. And in fifth step, you give daily oral prednisolone. And finally, when adequate control is achieved, dose of inhaled or oral steroids is lowered to a point where effective control is maintained. One important point to keep in mind while managing chronic asthma is that apart from drug therapy, avoidance of aggravating factors such as pollens or cockroaches or house dust mites, etc. Next is management of acute asthma exacerbation. And management of acute exacerbation is different from chronic asthma management. And as every management, this involves history, examination, investigation, and finally treatment. Investigations of acute asthma exacerbation are really important. These involve measurement of peak expiratory flow, arterial blood gas analysis, and arterial blood gas analysis will indicate type 2 respiratory failure in acute asthma exacerbation. This point is really important for your MCQs. One important point that I would like to mention here is that acute exacerbation of COPD will also result in type 2 respiratory failure. Now, the treatment of acute exacerbation of asthma involves administration of high concentration of oxygen, inhaled short-acting beta-2 agonists, oral steroids, intravenous fluids, and potassium supplementation. If the patient develops respiratory arrest, deterioration of arterial blood gases, confusion, or drowsiness, then intermittent positive pressure ventilation is started. And this is the reference page number of Davidson's Book of Medicine from where these answers are taken. Let's move to the next question. The question is, a 35-year-old male who is fond of keeping pigeons presents with low-grade fever and dry cough for 3 months. Examination shows clubbing and bilateral and inspiratory crackles and inspiratory squeaks, predominantly in and around apices and intercapsular region. This question was in annual examinations of 2015. The first part of this question is, what is your diagnosis? The second part is, write down investigations with expected findings. Third part is, write down management options. Before we answer this question, you can stop the video here and try to answer the question on your own. Great, so the diagnosis is hypersensitivity pneumonitis. And important points which led us to this diagnosis are bird keeping and predominant involvement of upper lung fields. Let's see the answers. See, here the diagnosis is hypersensitivity pneumonitis, which is also called bird fancier's lung. Remember that apart from bird keepers, this disease can also occur in farmers. The next question asked about investigations with expected findings. So, investigations are chest X-ray, which will show patchy airspace specification, high-resolution CT scan, which will show bilateral ground glass opacification and areas of consolidation predominantly in upper and middle lobes. As we discussed, this disease mostly affects upper lung fields. The third investigation which you can do is spirometry or pulmonary function tests, which will show restrictive pattern, which are given by FEV1 over FVC ratio of more than 0.8 and reduced lung volumes. The third question asked about management, which involves history, examination, investigation, and finally treatment. In history, severity of shortness of breath and occupational or recreational exposures to things which can lead to hypersensitivity pneumonitis should be asked, such as pigeons, hay, and some metals. Next would be examination, and in examination, complete respiratory and general physical examination must be done. And finally, the treatment involves ceasing exposure to offending agent. This is the most important step in the management of hypersensitivity pneumonitis. Also, dust masks with appropriate filters can also be used. In acute cases, oxygen and oral steroids are recommended. One important thing which can be asked about this disease are its complications, which are pulmonary fibrosis, pulmonary hypertension, and finally right heart failure. And here you can see reference page number of Davidson's Book of Medicine. Let's do the next question. The first question is, a 40-year-old smoker presents to the clinic with complaints of fatigue, weight loss, and fever for last 1 month. He has productive cough worse at night. Examination shows pulse of 110 per minute, blood pressure of 140/90 with tracheal shift to the left, and increased vocal resonance on left apex. Bronchial breath sounds are audible on left apex. This question was in supplementary examination of 2015. The first part is, what is the most likely cause of bronchial breathing? Second part is what is the most likely diagnosis. And the last is name drugs you would like to use to treat this patient, giving one side effect of each drug. The next question is, a 26-year-old laborer presented in OPD with history of fever, low appetite, easy fatigability, and weight loss for last 8 weeks. He also complains of productive cough for last 6 weeks and 3 episodes of hemoptysis over last 1 week. There are crackles in the left apex of the chest. This question was in annual examination of 2019. First part of this question is what is the most likely diagnosis. Second is give 2 important investigation most relevant to your diagnosis. And the last part is how will you treat this patient. Please try to answer the question on your own before we move forward. Good, so the answer is pulmonary tuberculosis. And as I discussed that students mainly struggle with reaching a diagnosis, so we will discuss some points in these questions which will lead you to this diagnosis. And these points are long history of fever, fatigue, and weight loss. Also, secondary TB usually leads to consolidation, which will result in examination findings given in these questions, such as increased vocal resonance, bronchial breath sounds, and crackles. And as secondary TB affects upper lung lobes, so all these findings will be in apical lung segments. Let's see the answers now. So the diagnosis is pulmonary tuberculosis and it is post-primary, which is also called secondary tuberculosis. As we know, primary tuberculosis affects lower lung segments and secondary tuberculosis affects upper lung segments. So this is secondary tuberculosis, which is also called post-primary. And as you can see in the picture, apical lung segment is involved. The next question was about investigation. So investigation done in the case of pulmonary tuberculosis are chest x-ray, sputum ZN staining, sputum culture, tuberculin skin test, and baseline blood tests such as complete blood count, ESR, and liver function tests. One important point here is that diagnosis of pulmonary tuberculosis is made by sputum culture, and this point is very important for your MCQs. The next question asked about the cause of bronchial breathing, and as we discussed before, the cause of bronchial breathing was consolidation of apical lung segments. The next question asked about the treatment. So total duration of treatment of pulmonary tuberculosis is 6 months with the following drugs: isoniazid, rifampicin, pyrazinamide, ethambutol. The last 2 drugs, which are pyrazinamide and ethambutol, are given only for initial 2 months, while first 2 drugs, which are isoniazid and rifampicin, are given for the whole 6 months. The side effect of each of these drugs is written in front, and the most common side effect is hepatitis, except for ethambutol, which affects eye and causes retrobulbar neuritis. One way to remember these drugs is by a mnemonic called RIPE, which stands for rifampicin, isoniazid, pyrazinamide, and ethambutol. As we know, TB is very prevalent in Asia, which makes it really important for examinations. So some important points to remember about TB are that physical findings on examination in a patient of TB are lymphadenopathy, increased vocal resonance, dull percussion, and bronchial breath sounds. Another important point to remember about TB is MDR-TB and XDR-TB. Both of these are becoming quite common in Asia, so it is important to remember them. MDR-TB stands for multi-drug resistant TB, and it is a strain of TB that is at least resistant to rifampicin and isoniazid. XDR-TB stands for extended drug resistant TB, and it is a strain of TB that is at least resistant to rifampicin, isoniazid, quinolone, and one injectable second-line drug. And here is the blue box, which will give you reference page number of Davidson's Book of Medicine from where the answers are taken. This finishes our discussion on respiratory diseases. Before ending this video, I'm sharing with you some bonus MCQs. These are made from some really important topics. You can solve these MCQs by stopping the video and write your answers in comments below. I'll share the answers to these MCQs in a comment below after a week of uploading this video. If you have any query, feel free to ask in comments below. I will be happy to answer. If you like this video, give a thumbs up and share it with your friends so that they can benefit too. Please subscribe and hit the bell icon for upcoming past paper videos. Good luck.